Good afternoon, seniors, my teachers and my dear friends. It's a proud privilege to stand before you in this afternoon to discuss on chronic constipation in children, which most of us face in our day-to-day practice. My pitch is neurodevelopmental pediatrics, and when this topic was given to me, I thought, okay, fine. This is also a problem of development. So I thought I will try to crack the hard party. So I will try to find out a soft solution for this hard problem. So the day-to-day scenario in most homes, most of the parents, when they come to the clinic for any other pediatric problem, at the end of the discussion, they will ask, sir, motion pora enna pannalam. So that will be a day-to-day scenario. A 3-year-old Harry is passing stools once in 3 days since 18 months of age, hard pellet-like, history of fear of defecation, often stands in the corners of the room, withholding maneuvers are there, history of fecal soiling is there. Whenever they go to some doctor, they ask for about this issue, and the intermittent use of laxatives. One doctor will give a laxative, the child will use for 10 days, then automatically that will get mildly improved, then automatically they will stop. So this will also be the scenario in most of the toilets of the children. So I'll try to find out soft solutions for this hard, brown, dry problem. So the flow of my talk will be, I'll find out the definition for what is constipation, the classification, the pathogenesis, why this constipation is occurring in children, the various types of poop, what are the investigations, whether we need any investigations for these children, management and prevention. So definition, we should remember these 4 Ds. Either a delay, child passing stools once in 3 days, or difficulty in defecation, passing daily, but the child has got a difficulty. That is because it is coming out hard. So both can be considered as constipation, sufficient to cause significant distress to the patient. So that constipation should cause a distress to the patient. What are the distress signs? Irritability, decreased appetite, and or early satiety. Because he has not passed potty for the past 4 days. So consider delay, D, difficulty in defecation, distress to the patient, and decreased appetite. All these are there, then you have to consider that this child has got a constipation. So constipation is not a disease. It is just a symptom. It is a symptom of a problem, and it is not a disease. It can be a manifestation of various diseases in the child. So this is a normal stool frequency in Indian children. Less than 1 month usually passes 3 to 4 times a day, or if the gastrocolic reflex is more, even multiple times. 1 month to 1 year, probably 1.5 to 2 times a day. 1 to 2 year, 1 to 2 times a day, or after every food because of the still the persisting gastrocolic reflex. Older than 2 years of age, potty trained, one time per day is the normal stool frequency. When will we call it as a chronic constipation? If the problem is persisting more than 4 weeks, we call it as a chronic constipation, and less than 4 weeks, it can be only a minor issue, and it can be an acute constipation. But understand that all chronic constipation starts acutely. It doesn't go from immediately to the 5th week. All starts at the 1st week, proceeds to the 2nd, 3rd, 4th, and then now we call it as a chronic constipation. Now comes the important question. All are because of organic causes, or most of them are functional. Like abdominal pain, chronic constipation, most of the causes are functional only. 95% of the causes are functional, and 5% only is organic. What defines functional constipation? As I already told you, it is a chronic constipation. So the problem should be more than for 4 weeks. 4 weeks problem along with the 2 of the following. What is that? defecation frequency less than 2 times per week, fecal incontinence more than 1 time per week after the acquisition of toilet skills. I will come back in the next slide. What is fecal incontinence? History of excessive stool retention, history of painful or hard bowel movements, presence of large mass in the rectum on periabdominal examination, history of large diameter stools that may obstruct the toilet. So if there is a 4-week duration of constipation history, along with two or more of the following in this, you can classify this as functional constipation. But I already told you there is a 5% of cases where you can have an organic cause, where this should also be ruled out. A anorectal malformation, anal stenosis, anteriorly placed anus, a neuromuscular cause where the common condition will be a Hirschsprung's disease, intestinal neurodysplasia, pseudo-obstruction, tethered cord, melingomylosia, CP, such things. Endocrine cause, not to be forgotten, hypothyroidism, where other manifestations of hypothyroidism will also be there. Medications, opiates, vincristine, antidepressants, lead poisoning, iron, important cause. The child must have been prescribed iron for 3 months. The dosage may be over. The child will be having constipation during the period when the child is taking the iron. Cystic fibrosis is one another cause. Cow's milk protein allergy is also one of the cause for organic cause, which is in the rest of the 5%. What are the red flags suggestive of organic constipation? Delayed passage of meconium, suggestive of hypothyroidism, Hirschsprung's disease, onset in early infancy, bilious vomiting, uniform abdominal distension, failure to thrive, recurrent respiratory infection, cystic fibrosis, code intolerance, neurodevelopmental delay, hypothyroidism, anal malformations, abnormal neurological examinations, that is lower limb and anorectal reflexes because of the spinal cord problem. All are red flags in the examination and history which are suggestive of organic constipation, which we are stopping as of now. We are going to deal only functional constipation now. As I told you, there is a history of fecal incontinence. See, previously in our undergraduate and postgraduate days, we must have seen this, taught these words of soiling, encopresis and all. But now the latest consensus statement from the ISPAGAN says that soiling or encopresis should not be used. It should be a fecal incontinence, that is defined as passage of stools in the undergarment, that is called as fecal incontinence. It can be a constipation associated one, or it can be a non-retentive because the child is not able to return the feces. It is causing a fecal incontinence. This is a very common scenario in most of the houses. The child will go to the bedroom, hide behind the wall of the bedroom or behind the cupboard, and then try to pass the stools. Child hides behind the furniture or goes to a corner, stands on the toes with the legs crossed or maybe red-faced. Such posturing suggests holding of the stools because the child doesn't want to pass the stools. So only when the stool is coming, the child will go to to that area, try to hold the stool. So that is called as a retentive posture. What the parent will think, oh, this child wants to hide somewhere and pass the stool. That is not the situation. So never allow the situation to occur. Never allow the child to go somewhere, stand, because this is a retentive posturing which the child is adopting, because when the child passes the stools, the child is having a pain. To avoid the pain, the child is going in for a retentive postures. This not to be forgotten. Urinary symptoms. Child will come for urinary symptoms. You will not ask the history of constipation history. Many children. When you ask for the constipation history, there will be a constipation history in many of the cases. There will be a urinary frequency, burning, crying during mixturation, urinary retention, suggestive of an urinary tract infection. It is known to occur with impacted stools as part of the constipation, lately described as a part of dysfunctional elimination syndrome, wherein the bladder bowel dysfunction set in due to several reasons like bladder instability due to the fecaloma, pushing the urinary bladder, or compression over the bladder neck, which inhibits the bladder emptying. So this is a very important condition. Whenever the child gives a history of constipation along with the urinary symptoms, always treat the constipation also. Coming on to the pathogenesis. What starts the constipation? Changes in the routine, changes in the diet, stressful event, postponing the defecation. The child starts school, the child is not able to spend time in the morning, so postponing the defecation, too early toilet training. What happens? There will be voluntary withholding. So what happens is voluntary withholding. When the potty is not passed within 24 hours, what happens? The reabsorption of fluids will be there in the large intestine. So there will be increase in the size and the consistency of the potty. So that will cause more pain when the child passes the stool. So painful defecation will be there. If there is a painful defecation, the child will go in for voluntary defecation. So this is a vicious cycle, and this goes on until the child develops an yeast fissure. Coming to the types of the potty, identifying the various types of poop, because you should ask the parent. So you should have the Bristol stool chart. So this is the Bristol stool chart. So type 1 is severe constipation. You should show the parent and ask, how is the potty of the stool of the child, whether it is type 3 like or type 4 like, or it is type 5, 6 or 7. So these are all normal things. 3 to 7 is normal. Type 1 is severe constipation. Type 2. One other person now has given an example for how the potty is. So type 1 potty will be like Maltesers. Type 2, whether it will be like a grape, or it will be like a crisp toffee or a sausage or a nuggets, or it will be like a oats kanji, or it will be like a gravy. You can ask them very easily, so that the parent will easily give the solution, will give the answer for that also. So this also somebody has given this history. Then coming to the history, a premature initiation of toilet training, you should ask whether the child was toilet trained only at 24 months. You should not toilet train before 24 months. Drug history is very, very important, which I will come in the next slide. Quick and abrupt transition of diet, liquid to solids. So that also to be avoided. Change in the local environment, schooling, start of a schooling, that is, the child will not be given time to potty, because child wakes up only at 8:30, goes to the school at 9 o'clock. Intercurrent illnesses. Drug history is very important. Antispasmodics for abdominal pain. There will be history of giving cyclopam, Drotin DS and all, because the child will not be potty, will not be passing stools. Because of the pain, the parent will start giving Drotavirin and dicyclomine to avoid the pain. So that will aggravate this problem, not will help the problem. Anti-diarrheal agents. Once the child develops diarrhea 3 times, then somebody in the opposite house will say, give a loperamide tablet, the child will get okay. So they will give a loperamide tablet, problem starts. Antitussives. Continuously the child will be getting some codeine, some dextromethorphan based cough formulas. Anticholinergics, because this is a rare condition. So, but others are very, very important. Intake of fruits and vegetables, very, very rare nowadays in families. Very, very rare to find it. Proper intake of fruits and vegetables. Refined food, very, very common. Excessive and prolonged milk intake. Mother will say, sir, yappa patalo, he will take only milk. I am saying, you are giving milk, so only the child is not taking the other food. The ayah will give, the nani will give milk at 12:30. How will the child take the solid food at 1 o'clock? It is not possible. It is very easy for them to give the milk, but very difficult. Packed food. So clinical examination, growth chart, it will no failure to thrive. Abdomen will be soft, no organomegaly. Perianal region will have a fissure. Perectal examination should not be done because of the painful fissure. Spine, no tuft of hair. Endoscopy, manometry, thyroid test, ultrasound abdomen, barium enema, not required to rule out a functional constipation. Coming to the management part, parent counseling is very, 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 very important. You have to tell them that long-time laxatives are very important because the problem is persisting for more than 4 weeks. Toilet training is important. Diet modification, drug therapy, and follow-up. Parent counseling, as I told you, should be clearly explained about the cause. Show some diagrams, show some videos, explain why this is happening. Any precipitating factors identified should be eliminated. Explain the need for long-term laxative. It is not a fever which will get corrected in 5 days. The child may need laxatives for 6 months. Toilet training to be started after 24 months. Rule of 1 to be followed. Only one person, the same person should give the toilet training. One routine, that is 5 minutes after a major meal. Make use of the gastrocolic reflex. After the child, you have seen many children, if you tell, go to the potty, they will not go. But after taking the breakfast, while running to the school bus, they will run. Oh, I am getting wet potty, I am getting potty. So that is, you're making use of the gastrocolic reflex. So it will be in the same place, in the same place, that is in the same bathroom. You should say only one word. They should say, the whole family should say the one word for that potty. Sit in the squatting position in the Indian toilet or with the footrest in the English toilet. So not in the Western toilet, because most of the houses have a Western toilet. So what is important? Why that is important? House squatting has the emptying. This is the puborectal muscle which will be choking the rectum. When you sit, it will be a partially relaxed muscle. But when you squat, it will be a fully relaxed muscle and the body will just move. So if you are having only an Indian toilet, you cannot ask the house owner to make a, Western toilet. You cannot ask the house owner for an Indian toilet. So what you can do, you can ask them to get a simple solution that you think, what is squatting, how this helps. And all these squatty potty is available in Amazon at various prices. And the third thing is the 3F, fiber, fluid, and fitness. Daily fiber diet is very important. Adequate intake of fiber-rich diet, serious, restrict the milk. Restrict the milk, very, very important. Only not more than 400 ml of milk per day, 2 times. Adequate water and physical activity. All these are very, very important things. Fibers containing good fiber containing vegetable. Mostly avoid vegetables which are below the ground level. Below the ground level vegetable contain mostly carbohydrate like potatoes, carrot. Not avoid, they are not helpful for these people. So you should take more vegetables which are above the ground level, which contain lot of fiber. All these fruits contain lot of fiber. Figs, cherries, bananas, everything contain lot of fiber. You can show the parent. You can even give them a printout what contain lot of fibers. Coming to the medical therapy, first very, very important is disimpaction. Disimpaction should be given till the child has a loose potty. Then the maintenance therapy should be continued for 6 months. Rationale for disimpaction, completely clear the colon so that no residual fecal matter is retained. This enables the rectum to achieve the normal diameter and tone for the proper anorectal reflexes and pelvic floor coordination. That is very, very important. The rectum has to come back to the normal diameter first. So maintenance should be started only after effective disimpaction. So the laxatives are osmotic laxatives and stimulant laxatives. Also, osmotic laxatives is the very, very first important is PEG. When I stand in Pondicherry and tell the word PEG, you will remind of something else. So PEG is nothing but polyethylene glycol. It should be given about 1 year of age. Various formulations are available, that is low 33350, 4000, something with the electrolytes, everything is available. So 3350 is more hygroscopic than 4000. Lactulose, only drug approved for children less than 1 year. Lactitol is also there, which is more palatable. Stimulant laxatives are also there. Sodium picosulfate, senna, bisacodyl. So this should not be used for disimpaction. Disimpaction should only be done with PEG. This stimulant laxative should not be used. Disimpaction with the PEG, polyethylene glycol, this is the home protocol. You should use 1.5 gram. Remember the one number, that is 1.5 gram per kg per day of polyethylene glycol, twice a day, 2 divided doses for 3 to 5 days orally till the passage of liquid stool. Don't go for the hospital-based protocol. So this is the disimpaction. Maintenance therapy, you can either use PEG or lactulose. PEG, it is 0.5. So 1.5 for disimpaction, 0.5 for maintenance. Bloating, abdominal pain, cramps can also be there. Dose of PEG, as I already told you, 0.5 for disimpaction. Sorry, 1.5 for disimpaction. I wrongly mentioned 1.5 for disimpaction, and maintenance it is 0.5. And for the benefit of newcomers and practitioners, these are the various brands which are available in the market. So polyethylene glycol brands, PEG brands which are available in the market. These are the various lactulose brands which are available in the market. These are the lactitol brands which are available in the market. Lactulose and lactitol can only be used in less than 1 year of age. Disclaimer, this is not a brand buying recommendation. Successful outcome of treatment, the stool normalcy while on laxatives for a period of 4 weeks. The child should have a normal stool for 4 weeks for a minimum period of 6 months. Then only you should start tapering the laxative. When to stop the laxative, no clear guidelines. Child should be made symptom-free while on maintenance therapy for at least 6 months before attempting to taper the laxatives. Taper it over 3 months. So the whole therapy goes on for 9 months. Behavioral modification, very, very important. Routine toilet sitting 5 to 10 minutes after the meals. Use the gastrocolic reflex. Maintain a stool diary. Reward method is very, very important. No punishment at all. So this is the star chart. You can put a star chart if the child has passed the potty the day. That is Monday, if the child has passed potty, you can put a chart. Start. At the end of the week, you can give some reward for the child. This can be shown to the parents and advise the parents. Follow up. You should be weekly follow up, then fortnightly. Stool diary is very important. Start gradually and reduce the dose gradually. No abrupt stoppage of treatment. Commonest cause of recurrence is premature withdrawal of the laxatives. This is the algorithm which I already told you is in the algorithm. Rule out the red flags. No red flag. Functional constipation. Functional constipation is proved. You have to go for fecal impassion and disimpaction with the PEG, that is 1.5 grams per kg per day. Maintenance laxative therapy with the PEG is 0.5. Follow up. Successful outcome, gradual weaning, no relapse of substances, stop medication and follow up. So this is the algorithm. Preventive strategies, minimize psychological stress, parental attention, physical activity, diet, build a safe society for children, correct toilet training, all are very, very important. So I have found out the soft solutions. What are the soft solutions? Daily routine, diet, and D. These 3 Ds, if you follow, you can avoid the hard problem, which is delay, difficulty, and distress, so that such agonic phases can be converted into sweet phases. And thank you very much for this opportunity to present before this august guardians.
Thank you, sir. Thank you for your clear guidelines. Thank you. But for the most of the parents, the maintenance therapy is the problem. They start correctly, but after some time they stop giving continuously. Easier 4 to 6 months, but they are finding it difficult. But somehow as pediatricians, we will have to persistently ask them to give. That is the only idea of peace lecture. Thank you, sir. Now, madam will take over the podium.
Good afternoon.